yellow phosphorus. So this is the first element to be isolated. It is known as white phosphorus. The white is also known as a yellow if with impurities, especially the red phosphorus. It is a waxy whitish to yellow solid with a melting point of 44.1 degrees centigrade. Lethal dose is around 1 milligram per kilogram, same with the toxic dose. Insoluble in water and congestion with fats, alcohol, and liquids increases toxicity. The phosphorus pentoxide, which usually appears as a white fume having a garlic-like smell, and the chemical component of watusi, the dancing firecracker watusi, is yellow phosphorus. There are three mechanisms of tissue injury: the exothermic reaction, the acid-producing corrosive reaction, and the dehydrating reaction. So the phosphorus is cited as being a general protoplasmic poison. So it is recognized as a potent hepatotoxin, and patients who survive the initial neurologic and cardiac stress of acute poisonings may manifest with hyperbilirubinemia, coagulopathy, hypoglycemia, and elevation of transaminases. Liver injury pattern is classically periportal. Microscopy would show extensive necrosis, ballooning, degeneration, and steatosis. For clinical manifestation, it is divided into three stages. The first stage, we have the GI irritation symptoms. Second stage, the transient resolution of the toxic effects. And the third stage is the hepatic injury with coagulopathy and jaundice and acute kidney injury. Significant ECG changes might also be seen, mimicking myocardial infarction. Recovery usually occur over 1 to 2 weeks. For diagnostics, the diagnosis of phosphorus poisoning must rely on the history and physical examination. So evidence of cutaneous or mucosal burns, there is garlic odor in the vomitus or the feces, the smoking stool, and luminescence of vomitus and feces also. So ECG, electrolyte, serum pH, hepatic function monitoring is very important, especially the ionized calcium for electrolytes, and also renal function, coagulation parameters, reticulocyte count, and blood typing, and then EGD, to assess if there is a ulceration or probable perforation in the GI tract. Other laboratory measures are enumerated, such as CPK-MM for rhabdomyolysis, CPK-MB for myocardial infarction. So especially for watusi, the approach of management is stabilization of the patient, avoid oxygen unless patient is hypoxic, give raw egg whites, 8 to 12 for adults and 6 to 8 for pedia. So do not include the yellow part of the egg. Do not insert in GT, in PO, and then the adjunct treatment is in acetylcysteine. You can give initially vitamin K1, 1 milligram per kilogram, but you will not exceed 10 milligram in pediatric patients for a possible hypoprothrombemia. So ascorbic acid in the presence of documented methemoglobinemia can be given every 6 hours, that is 500 to 1000 milligram IV, or for pedia 10 to 20 milligram per kilogram IV. For other cases of white or yellow powder phosphorus ingestion, still there's no antidote, and incomplete decontamination, especially for the dermal exposure, would delay wound healing. Milk might also be potentially harmful because of its lipophilic components, therefore it increases absorption. Activated charcoal may bind to white phosphorus and could be considered if no contraindication. So decontamination efforts should be strongly considered with ordinary cold tap water, which serves as a heat sink. Unlike in watusi, you cannot insert EGT and also cannot lavage with water. Keeping the free end of the OGT and NGT underwater while inserting in stilling small amounts of water, not air, because it can react with the phosphorus, and you can have exothermic reaction with air and also explosion. So this, if you would check the patency of the NGT or OGT, so check it with water. Next is the